In adolescent mental health, there is a specific behavior that contradicts our basic clinical instincts. The DSM-5 categorizes it as non-suicidal self-injury, or NSSI. It is defined by intentional, self-inflicted damage to the surface of the body. The strict defining characteristic of this condition is the absolute absence of suicidal intent. This means frontline workers, educators, counselors, and pediatricians must discard the assumption that this behavior is a failed suicide attempt. The clinical data shows that the behavior functions instead as an active, deliberate coping mechanism used by adolescents to manage overwhelming emotional states. This split-screen graph maps the paradox clearly. On the left, suicidal intent remains flat, but on the right, we see a sharply rising line. Engaging in NSSI is actually one of the strongest clinical predictors for future suicide attempts. Frontline professionals have to reconcile this exact contradiction. A behavior used to manage life is a primary indicator of a risk of ending it. Properly triaging at-risk youth depends on understanding this. This is not an isolated presentation within the U.S. adolescent demographic. This population block chart shows the scope. Up to 17 to 18% of U.S. adolescents will engage in NSSI at some point. In a standard high school of 1,000 students, that translates to roughly 170 teens navigating this exact dysregulation. Because this presentation peaks during the K-12 years, the burden of initial discovery falls almost entirely on educational staff and primary care pediatricians, rather than psychiatrists. The sheer volume of these cases, combined with their high lethality risk, means institutions cannot rely on ad hoc reactions. They require a standardized, protocol-driven response. To understand why standard disciplinary or counseling methods fail, we have to look at the psychological mechanics. The DSM-5 classifies NSSI when the behavior occurs on 5 or more days within the past year. It is driven by 3 specific psychological goals. The first is seeking immediate relief from acute negative emotions. The second is attempting to resolve a severe interpersonal difficulty. And the third is artificially inducing a positive emotional state when feeling dissociated or numb. This cyclical flowchart represents how those psychological goals map onto physical actions. We start at node 1. A negative emotion or conflict triggers the second node, the NSSI action. This action phase typically involves methods like cutting, burning, scratching, or hitting oneself. This leads to node 3, transient relief. That temporary drop in distress actively reinforces the cycle, trapping the adolescent in a continuous behavioral loop. Because this reinforcing loop is so deeply ingrained neurologically, generalized, non-specialized counseling lacks the specific clinical tools to intercept and dismantle it. The immediate challenge for frontline workers is detecting a behavior that is deliberately designed to be hidden. The most direct physical warning sign is the presence of unexplained, patterned injuries. Adolescents frequently use strategic clothing choices for concealment. You will often see a student wearing heavy, oversized long sleeves or hoodies in hot weather. You will also see rigid situational avoidance. A student may exhibit a sudden, staunch reluctance to undress for physical education, swimming, or routine medical visits. Broader behavioral shifts accompany these physical signs, including sudden social withdrawal or abrupt mood changes. These subtle markers are frequently the only visible evidence of a severe internal dysregulation loop, requiring aggressive vigilance from educators and pediatricians. The moment NSSI is discovered in a school or clinical setting, it triggers an absolute triage mandate. This routing pathway diagram shows the critical decision point. Placing a student into isolated, generalized school counseling is clinically contraindicated and dangerous. The correct clinical path splits into 2 concurrent mandatory actions: an immediate clinical referral and required family involvement. Isolated counseling fails because it relies on cognitive processing, which an adolescent in a state of acute emotional dysregulation simply cannot access. Instead, patients require the clinical gold standard for treating NSSI, dialectical behavior therapy adapted for adolescents, or DBTA. A secondary evidence-based option is mentalization-based therapy for adolescents, or MBTA. Both DBTA and MBTA are backed by rigorous randomized controlled trials. They also share a structural requirement. Both therapies absolutely mandate integrated family involvement to succeed. Frontline Discovery must function strictly as an alarm system to route the patient to RCT-validated therapies, never as the treatment endpoint itself. There is systemic friction here. K-12 schools rarely possess the internal infrastructure to seamlessly route 18% of their population to specialized DBTA care. Comprehensive K-12 mental health support systems bridge this gap. MentalSpace School provides the structural blueprint for this integration. A central school node routes directly to external, dedicated teletherapy teams and family counseling nodes, providing same-day crisis intervention. To function in education, rigid security borders surround the system, adhering strictly to HIPAA and FERPA regulations. Integrating the system immediately secures institutional compliance with upcoming mandates, such as Georgia's HB 268, well ahead of the July 2026 deadline. To address the socioeconomic barrier, these systems utilize universal insurance acceptance, processing Medicaid at zero cost to ensure equitable access. Utilizing an integrated teletherapy framework turns a high-risk liability into a streamlined, medically sound, and legally compliant clinical pathway. The value of this specific protocol is proven by its measurable real-world impact. Routing students to specialized care results in a 92% reduction in adolescent anxiety. This dashboard displays the resulting institutional outcomes. Successfully managing NSSI yields an 89% improvement in student attendance. We also see an 85% family satisfaction rate, validating the mandate for integrated family involvement. When institutions respect the clinical paradox of NSSI and utilize dedicated infrastructure to route students to RCT-validated care, they prevent future suicide while restoring the academic and emotional futures of their students.